I feel like now I should advocate for Butlerian jihad and just get us all started on overthrowing the machines. Um, Thank you so much for having me and my team out to speak about this paper that we've put together. This was a really auspicious conference to find for the kind of work that we're doing. Let me make sure that I know how to do this. Here we are. Here we are. So back in 2022, we stumbled across what we thought was like an interesting question, which is how are preprints being used to guide US government policy? Now, the short answer to that is you'll never know because most government policies don't have long citation lists. So that's a more difficult question to answer. But one thing we did discover we can do is we can look at the way that policy guidance, right, distinguishing this from the actual policies that get put together by state and national governments, to understand what role preprints play. And in the case of COVID-19, the reason that we had this question is that this was, as some said, really the first kind of global infectious disease outbreak that was at least partly, if not kind of in a very significant sense, adjudicated through the use of preprint repositories. So early access data that was then being picked up by media, by government, in order to guide public opinion, but also decisions. And so we wanted to know how these preprints were used, and in particular, what were the consequences of using preprints over, say, waiting for a publication of, a published version of record to appear before you actually use the data, the information, the knowledge to guide policy. And so we decided to look at two forms of this, so two corpuses of policy guidance. One is the DHS, the Department of Homeland Security's master question list for COVID-19, which in 2020 and 2021 was released daily, usually by DHS, and then the weekly NIOSH questions and answers about COVID-19 in the workplace. And so we took both of these corpuses over a period of a year from February 2020, when the first of these policy guidance documents came out, through to February 2021, and we took a snapshot of these guidance documents, one a week, and we wanted to strip out all of the preprints that we had and then compare those preprints to their published versions of record. Now, of course, that's hundreds of thousands, if not millions of lines of text just to read the abstracts alone. So we enlisted the help of everyone's favorite right now, artificial intelligence, but in this case, just the very prosaic natural language processing that's been going on for decades at this point. So we took the abstracts of a preprint and its what we call postprint, its published version of record, and we would compare the abstracts to look at how information was represented and if anything had changed in the paper that was significant to the clinical or scientific outcomes of the paper itself. And the way that we did this was we at first stripped the XML out of the papers, and we got the raw text of their abstracts, and we then aligned the sentences using a sentence alignment function, and then we extracted those edits. So we tokenized the sentences, and then we compared the structure of those sentences from one paper to its published version of record to look at what changed. So this uses natural language processing to do intention analysis. And so our algorithm was able to pick up simplifications of language. So in this paper on the clinical benefits of methylprednisone in treating severe cases of COVID-19, simplifications, the insertion of content where there was no content before in a sentence, significant deletions, and then changes in sentiment or typographic changes in style that went along with the journal publication process. We then subjected this to qualitative coding. So this involved myself and one of my colleagues who's here today reading these pairs of sentences with the identified changes to try and figure out if those changes constituted something scientifically or clinically significant. Unfortunately, we did not have an algorithm that could do this for us. So this involved looking at what our natural language processing algorithm had identified as 10,483 pairs of sentences across 464 papers across our corpus, and then screening them to see if they had just potential significance to the policy guidance. At which point we would then, we ended up with 1,200 sentences over 329 papers. And then we would validate these. So we would ask, is this a significant change in between the preprint and the published version of record? If it is, what type of change is it? So did the preprint say, hey, there is a significant effect, and now the publication of record says there's not a significant effect? Did they add covariates? Did the context change such that they were testing something in the absence of any meaningful trials of an intervention, and then once it was published, they were one in dozens of trials that had been conducted on a particular intervention? And then we would pass these to adjudication with the entire team, which was multidisciplinary between epidemiologists, clinical researchers, political scientists, and data scientists, to adjudicate the hard cases about whether or not something really was a significant change. And then we would identify qualitatively what kind of the details of those changes were for future reporting. We would then go back to the policy documents. So with our 52 kind of truly significant sentences, we would, across 46 papers, we would then look at whether the change in the paper constituted a change in the policy. So counterfactually, if the policy had just relied on the published version of record, would it have recommended something different? And then finally, we looked at whether or not those preprints were ever updated in the policy documents themselves. So if the policy document is citing, medRxiv /10.10011, et cetera, does it now cite JAMA, BMJ, NEJM, et cetera, et cetera? So the results at a glance are this. So we found 75 sentences across 42 papers. So our reviewers said that per paper analysis was a nicer way, so I'm just going to continue with that. And so we found 42 papers within the NIOSH documents that, if we had relied on their published version of records, would have actually made a change in the kinds of guidance that were being offered forward by the policy guidance. We found 92 of these papers in the MQLs. Interestingly enough, they weren't the same set of papers, so those sets are non-overlapping. There's not like a problem paper that's kind of weaving its way through all the US government policy documents, having this effect. These were quite separate policy document corpuses. And of those, we found 17 papers in NIOSH that would have influenced policy, and 29 in the MQLs. And only 9 of those papers were updated in the NIOSH corpus, and only 1 of those papers was ever updated in the MQLs. Interestingly enough, there are differences in the ratios of these as a function of the size of the corpuses. So the MQLs had far more policy impacting changes, where if they had used the published version of record, they would have suggested something different to what they actually did, and also had far fewer updates relative to the number of errors. So to finish off, I'm going to give you some qualitative examples of these issues. So the first paper to predict the basic reproductive number of COVID gave an R0 value of 3 with a confidence interval of between 0 and 24, which for those of you who know your epidemiology is a large confidence interval. And this was actually reported as a range in one of these policy guidance that public health agencies should anticipate an R0 of up to 24, which is worse than measles by a considerable margin. The final value is actually 4, between 2 or 7, and so that guidance was never updated. That just kind of sat there. An early attempt to document transmission from school children back to family members, which, as some of you remember, was a serious issue, actually found no association in the preprint, and then was reanalyzed and found a significant association between children getting COVID at school and then transmitting it back on to family members. I'm running short on time, so I'm happy to talk about a couple of other of these in the comments. Sorry, in the questions. So really quickly, here's kind of the top line things that we concluded. Preprints do get it wrong, But in policy guidance, how often they get it wrong and how much that matters actually is determined quite significantly by the policy groups themselves, right? So who you have reviewing the papers that are going into your guidance really matters. So there are these large differences between different policy groups into how often they get it wrong and how often they change when things go wrong. Moreover, all of the preprints that were used in these policy guidance had a publication rate of 81%. So 81% of all of these preprints made it to publication. This is compared to the 20% publication rate that all COVID preprints had during the acute phase of the pandemic. So this was a significantly, let's say, higher quality fraction of preprints if we judge quality by their ability to get published. The last one that I'll talk about before I move to questions is not all of the ways that preprints get it wrong matter in the same way. And this is because often very scientifically interesting ways that preprints will get something wrong that will then be picked up in peer review have no bearing on pandemic guidance. Why is that? Because the Department of Public Health doesn't care which genetic marker of a variant of concern you picked out. They just want to know whether or not you need to wear a mask, which you do. So a lot of the ways that science gets it wrong actually don't matter to policymakers at the moment of these acute outbreaks. But in some cases, what does get caught in peer review really does matter. And in particular, papers that had clinical decision-making impact that got it wrong were reported in policy guidance, and at least in anecdotal versions we've seen have been picked up in state and national public health policy that were then not changed later once the postprint comes out. Why? Because no one's got time these days to read all the preprints in science and compare them manually against their published version of records, except for us, which we did. And it was a huge effort, and I'm proud of my team for doing it. So I'll open to questions.
In the front.
Johnny Anidis from Stanford. That's a fascinating study. You have about 20% of preprints used by policy that never got published. I mean, were they wrong? Could you somehow compare against what is the current status of knowledge? And one clarification, what percentage of the citations in these documents, in the policy documents, were preprints versus full papers?
If I remember correctly, approximately 30% of all of the citations in these policy documents, no, it was much more than that. I think it's almost 50% were preprints at one point, right? And of these, the majority of these get converted, but very few of them get updated in the policy corpus. What happens to these 20%? So as a comparative study, there was nothing to compare them to in terms of their published version of record. And by the time we got through our sentence pairs, I think we were done for this one, and kind of let's get this out the door. I think that so we have kind of two things that we want to do next. One is to actually look at the remaining 20% and to then do a kind of a quick scoping review to look at how the knowledge changed over time to see did were these contemporaneous with what ended up being the gold standard for this particular piece of knowledge, or did they kind of fall out in the end? The other we would like to do is take this corpus and use it almost like a trace and go through all of the policy documents we can using a database like Overton to see where they pop up in other international. So actually use this as like the basis for kind of screening policy documents at a wider level.
Thank you. Yes, a few questions. First is a comment from Theo Bloom of the BMJ and MedArchive. Many preprints posted during COVID were deliberately ephemeral. For example, a group posting monthly updates of incidence figures. So using subsequent publication as a marker of quality isn't really appropriate, particularly during the early part of the pandemic. Can you comment?
So again, I think that this, and this is kind of the sub-analysis we're doing right now, is that I think this depends on like the particular disciplinary specialty that you're talking about. I think that for rapid updates, so I'm thinking like Nigel Ferguson's group or something like that, you know, and kind of the way that they were doing modeling, I think that is true that the actual published version of record isn't indicative of the kind of the evolution and the overall quality. But I think that if we're talking about a randomized control trial of a particular clinical intervention, even if it is updated and that's kind of a measure of its scientific quality, when it comes to actually being picked up by policymakers. The fact that they're looking at version 1 of medRxiv and they're not going back to like version 7 and being like, oh, they actually fixed it, is maybe not a measure of quality of the science, but of its impact on policy, whether or not it turns out to be high quality.
Great, thank you. And I think there's nobody else, so I'll ask from Juno Shiro in the Mayo Clinic, wondering whether the activities and actions or behaviors observed during a time of global crisis are representative of behaviors during a less unusual time.
Yeah, so we wanted to know about the time of global crisis, right? And so I think that the way that we can make inferences about the function of preprints overall might be different between like emergent modes, let's say, and then kind of regular science. COVID was also like a moment where preprints were used in an outsized way, in the sense that not only does their relationship to policy maybe not be representative because of the crisis, but their relationship to policy might also be different in virtue of their scale of use, right? Perhaps one other, though, kind of interesting one that I don't want my team to go through yet, but maybe I'll make them do it, is a lot of the way that we talk about AI safety right now is through the language of preprints, right? And now that's not a crisis in the same way as COVID was, but it is emergent in the sense that we have a very large speculation bubble. We have a lot of people's careers riding on this stuff. And so maybe we can look at like the evolution of preprints as a knowledge source for AI safety in a similar kind of way. So I think in terms of these high influxes of preprints, I think that this is a very specific kind of analysis. I'd have to think about how we would do this for like a more endemic use of preprints.
Yeah, that's a great idea. Thanks. Also, medRxiv had just launched 8 months before. So the whole notion of
Right.
preprints in the medical space specifically
It's
is
totally novel, right?
relatively new.
Yeah.
Thanks.
Markus Krevars, Helsinki, Finland. Thank you. Very nice. So I'm an intensivist. So I worked in the ICU during the COVID pandemic. And of course, in the beginning, we had nothing. They were just on ventilators. And then there was some small, and there was lots of studies, corticosteroids and all these. But of course, if we think about the actual effect of many of these interventions, I mean, they weren't massive. There was small differences. So I sort of wonder, I mean, is there a need for the policy document to change so incredibly quickly when the interventions that we develop are sort of probably not, I mean, they're not magical bullets. It's small changes. And for example, steroids, I mean, there's still debate about the British study. Was it actually effective? Because the findings were a bit contradictory. Without oxygen, it harmed you. With oxygen, it may have improved you. So is it still, how do you feel about that? I mean, how is it important for the policy document to be updated very quickly? Or is it actually good to wait a while when, for some reason, the interventions for a horrible disease like this are not magic bullets? They make small changes.
So as an Australian who was in the United States during the pandemic, watching my father go through the Australian policy response, which was not, grounded in like rapid uptake of preprints. They just said, yeah, nah, we're closed for business, and then they were done. I think that country by country response is going to be very, very different. And discipline by discipline response might be very different as well. But my sense is that, and this is conjecture on my part, my sense is that the rate in the US at which policy guidance was being developed and kind of deployed was not necessarily productive to large gains in the public health response, right? In the same way that like litigating, whether methylprednisone actually works for severe COVID patients in the absence or presence of ventilation on Twitter, which is definitely a thing that happened during COVID, it was like also not a terribly productive use of anyone's time. These daily reports, whether or not they were productive to the overall policy response in the United States is a different question that this analysis can't answer. But one thing that I think would be interesting to look at is to do cognitive interviews with different people in different kind of pandemic roles around the degree to which the DHS daily master questions list was deemed to be useful and/or whether or not anyone had ever heard of it, but also the degree to which they found preprints, like kind of rapid breaking knowledge, actually useful in, for example, clinical care. Because I have anecdotes from my colleagues in the medical profession, but I don't necessarily have a good sense of the degree to which different medical practitioners actually found this torrent of knowledge to be useful meaningfully to taking care of their patients. And then there's like the separate quantitative question about whether there was actually like motion in the needle around overall like large scale clinical outcomes for a country as a result of, preprints or anything like that.